Okay. Hello, everyone, and thank you so much for joining us today. My name is Kristina Stolitka, and I am a Health IT advisor with the Kentucky Regional Extension Center. I will be walking through today's slides on the Medicare Promoting Interoperability program for hospitals. Our goal today is to simplify the 2026 program requirements and help hospitals clearly understand what they need to do to successfully participate and avoid Medicare payment adjustments. All right. First, we will review the Medicare Promoting Interoperability Program requirements for 2026, including what has changed, what's expected, and how to determine whether your hospital is on track. Next, I'll highlight key takeaways from the most recent inpatient prospective payment system proposed rule, focusing specifically on the updates that may impact PI participation moving forward. And then finally, we'll wrap up with some key action items and important reminders to help you prepare for the program year. All right, we'll start with a brief refresher of the program and then move into the 2026 requirements, scoring, and reporting timelines. I'm not going to spend a lot of time looking back, but just as a quick reminder of how we got here, the American Recovery and Reinvestment Act of 2009 directed CMS to incentivize hospitals to adopt, implement, and upgrade certified EHR technology. In response, CMS launched the EHR Incentive Program, formerly known as Meaningful Use, in 2011 under the HITECH Act. The program rolled out in progressively more advanced stages and initially included incentive payments, which continued through 2016 for most hospitals, depending on when they started. As the program moved through stages 1, 2, modified stage 2, and then ultimately stage 3, CMS continued advancing certified EHR technology requirements while evolving objectives, measures, and electronic clinical quality reporting. Over time, CMS redesigned the program to increase flexibility, reduce provider burden, and place emphasis on electronic exchange of health information. The focus shifted toward interoperability, patient access to health data, and improved information sharing across care settings. The Medicare Promoting Interoperability program, as we know it today, includes a set of objectives, measures, ECQMs, and participation requirements that determine whether an eligible hospital or critical access hospital meets meaningful user standards. And although incentive payments ended several years ago, hospitals must still successfully participate each year to avoid a Medicare payment adjustment. And importantly, unlike many other CMS programs, the PI program does not have a defined end date. So even after all these years, CMS continues to evolve the program, shifting it from an EHR adoption initiative into a broader interoperability, cybersecurity, and health IT safety program. At the beginning here, I want to highlight the key policies that were finalized last year and take effect for the 2026 program year. First, CMS will continue using a 180-day reporting period for 2026 and beyond. So there are no surprises here, and hospitals can plan around a consistent reporting timeline going forward. While this provides stability, it also means there's less flexibility than in earlier years. Hospitals should really assume PI performance needs to be monitored throughout the year, because if performance drops midway through the reporting period, recovery opportunities can be limited. Next, CMS strengthened the security risk analysis requirement, and this is one of the most important changes for 2026. Previously, hospitals simply attested yes or no to completing a security risk analysis, essentially answering the question, did you do it? Beginning in 2026, hospitals must also attest that they have implemented a risk management plan consistent with the HIPAA security rule. This means CMS is no longer asking only whether risk was assessed, but whether organizations actively took steps to reduce identified risks. Cybersecurity is now being framed as an organizational governance responsibility rather than just an IT task. And documentation must demonstrate mitigation efforts, not just completion of an assessment. Next, let's talk about the safer guides. These are evidence-based best practices designed to improve the safety and usability of EHR systems. Originally released in 2014 and updated in 2016, CMS incorporated the safer guides into the PI program in 2022, and then they became mandatory beginning in 2024. For the 2026 program year, hospitals must transition to the updated 2025 safer guides. These new guides place much greater emphasis on safe EHR use, system resilience, and cybersecurity practices. Completion should involve multidisciplinary participation, including clinical leadership, compliance, quality, and IT, because CMS is increasingly connecting patient safety directly to health IT operations. And then finally, CMS added a third optional bonus measure under the Public Health and Clinical Data Exchange objective. Hospitals can earn bonus points by attesting to active health information exchange with a public health agency through TEFCA, the Nationwide Framework for Trusted Health Information Exchange. While participation earns bonus points today, CMS is clearly signaling that nationwide exchange participation may become an expectation in the future. So overall, CMS did not redesign the Promoting Interoperability program for 2026, but they did clearly raise expectations, particularly around cybersecurity, governance, and advanced interoperability. This slide outlines the overall framework of the Medicare Promoting Interoperability program for 2026. So as mentioned earlier, the reporting period remains a minimum continuous 180-day period. Hospitals may still choose a longer reporting period up to the full calendar year if that better fits your operations. In addition to reporting the PI objectives and measures, hospitals must also submit 4 calendar quarters of ECQM data, which continues to be a core participation requirement. Hospitals are also required to use certified health IT that meets current ONC certification criteria. And you may remember this was previously referred to as the 2015 edition, but CMS and ONC have moved away from naming certification standards by specific edition years. I also want to briefly reinforce the 2 requirements we just reviewed, the strengthened security risk analysis, which now includes risk management activities and completion of the updated safer guides. For 2026, CMS continues using a performance-based scoring model, but the passing threshold increases again. Hospitals must now earn at least 80 points to successfully attest. That's up from 70 last year and 60 the year before. So this represents, again, another one of the most significant practical changes for hospitals because fewer points means greater financial risk. In short, this is not a year to take your foot off the gas. And then finally, the attestation deadline for the 2026 program year is already established as March 1st, 2027. All right, for 2026, hospitals will continue reporting the same 4 main objectives within the Promoting Interoperability program. This slide shows how points are distributed across each objective and its individual measures. First, the electronic prescribing objective, which includes generating and transmitting permissible prescriptions electronically, along with the query of Prescription Drug Monitoring Program, or PDMP measure. Next is the Health Information Exchange objective, which focuses on interoperability and using health IT to support care coordination. Hospitals have 3 reporting options again, but only need to select one. These include the traditional support electronic referral loops measures, so sending summaries of care and receiving and reconciling health information, or one of the alternate options, engagement in bidirectional exchange through an HIE or enabling exchange under TEFCA. The next objective is provider to patient exchange, which centers on giving patients timely electronic access to their health information and supporting patient engagement. And then finally, the public health and clinical data exchange objective. So for this objective, hospitals attest yes to being in active engagement with public health agencies or clinical data registries to electronically submit required data using certified EHR technology. In 2026, hospitals must report on all 6 mandatory measures. So immunization registry reporting, syndromic surveillance, electronic case reporting, electronic reportable laboratory results, antimicrobial use surveillance, and antimicrobial resistance surveillance. In addition, there are 3 optional measures available that allow hospitals to earn bonus points. Okay, now let's dig into some of the details. And I know this part can feel a little tedious, but it's important that we walk through it carefully. I don't want anyone assuming they already understand the measure and then accidentally miss a key requirement. So first up, the electronic prescribing objective includes 2 required measures, e-prescribing and query of PDMP. Both are mandatory and worth 10 points each. For the e-prescribing measure, medication orders for permissible prescriptions must be checked against a drug formulary and transmitted electronically using certified EHR technology. The second measure is the query of PDMP. Hospitals must use data from CERT to query a PDMP for a patient's prescription drug history. CMS expanded this requirement a few years back. It's no longer limited to Schedule 2 opioids. Schedule 3 and 4 controlled substances are now included. Another important detail, CMS requires the PDMP query to occur before the electronic prescription is transmitted. Because PDMP workflows vary by state, CMS does allow flexibility. Hospitals may perform the query in any way that is legal and practicable within their state. And CMS also does not require that CERT connects directly to the PDMP system. So what does matter is documentation, and hospitals should be able to demonstrate that the functionality exists, the query action occurred during the reporting period, and internal policies support how the measure is performed. And we strongly recommend collecting supporting documentation throughout the year. Doing this gives you flexibility later when selecting your reporting period if performance needs adjustment. So while CMS did not finalize new PDMP requirements for 2026, last year's rule included requests for information, and that signals where the program may be headed. CMS is evaluating whether future policies could measure actual clinician PDMP use, expand monitoring across additional controlled substances, and further align PDMP activity with federal opioid safety initiatives. So for now, there is no new mandate for 2026, but this is clearly an early signal of future expectations. Next is the health information exchange objective. Hospitals have 3 different reporting options. You only need to select one option to meet program requirements. Option 1 involves completing both the sending and receiving electronic referral loop measures. The first part is support electronic referral loops by sending health information. When a hospital transitions or refers a patient to another setting of care or provider, the hospital must create a summary of care record using CERT and electronically exchange that information with the receiving provider. The second part is support electronic referral loops by receiving and reconciling health information, or at least one electronically received summary of care record, either during a transition of care or for a new patient the hospital has not previously encountered. The hospital must perform clinical information reconciliation, including medications, medication allergies, and the current problem list. Now, these 2 measures must be completed together to count as option 1. Hospitals report a numerator and denominator for each measure worth up to 15 points each for a total of 30 possible points. There are no exclusions available. Option 2 is the HIE bidirectional exchange measure. So instead of counting individual transactions, this option allows hospitals to attest yes or no that they actively participate in bidirectional exchange with a health information exchange. To attest yes, the hospital must confirm participation in an HIE that enables secure bidirectional exchange for all unique discharged patients whose records are maintained in the EHR during the reporting period. The HIE supports exchange across a broad network of unaffiliated partners using different EHR systems and does not restrict exchange participation. And the hospital uses CERT functions to support this bidirectional exchange. This option is yes or no attestation worth 30 points. And then option 3 is the enabling exchange under TEFCA measure. For this option, the hospital must attest that it participates as a signatory under the TEFCA framework agreement and enables secure bidirectional exchange of patient information in production for all unique discharged patients whose records are stored in the EHR. The hospital must also confirm that the certified EHR technology is used to support this exchange under the TEFCA framework. So like option 2, this also is a yes or no attestation worth 30 points. And again, hospitals only need to choose one of these 3 options to successfully meet the health information exchange objective. Next is the provider to patient exchange objective. This focuses on ensuring patients have timely electronic access to their health information. Hospitals must make health information available so patients can view, download, and transmit their data online. Hospitals must also support patient access through third-party applications using secure APIs that meet the technical specs of their certified EHR technology. So in other words, patients must be able to access their information using the app of their choice when it's properly connected. There are no major updates to this objective for 2026. The measure continues to be reported using a numerator denominator, carries up to 25 points, and there are no exclusions available. CMS continues to view patient access as a core interoperability requirement. So hospitals should ensure patient portal adoption and API functionality remain active and monitored throughout the reporting period. Right. Lastly, we have the public health and clinical data exchange objective. So most Kentucky hospitals meet these requirements through participation with KHI, the Kentucky Health Information Exchange. For 2026, hospitals must report on 6 required measures. Again, the bidirectional immunization registry reporting, syndromic surveillance, electronic case reporting, electronic reportable laboratory results, antimicrobial use surveillance, and antimicrobial resistance surveillance. Now, together, these 6 required measures account for a total of 25 points under this objective. I do want to specifically call attention to the antimicrobial use and antimicrobial resistance measures, which are both reported through the CDC's National Healthcare Safety Network, or NHSN. In 2025, CMS treated AU and AR as newly separated measures, which allowed hospitals to use option 1, active engagement, again. Beginning in 2026, that flexibility ends. Hospitals are now expected to have progressed to option 2, validated data production, consistent with the expectations for all of the other public health measures. And then finally, there are 5 bonus points available under the public health objective. Hospitals may earn these bonus points by participating in a public health registry, a clinical data registry, or the new public health reporting using TEFCA measure. And just an important reminder, participation in these measures is optional. However, if you choose to report any of them, the bonus is 5 total points, not 5 points for each registry. All right, and before we move on, I do want to take a moment to review active engagement, which is an important component of the public health objective. During attestation, hospitals must indicate their level of active engagement for each public health measure. In recent years, CMS simplified and renamed these engagement options. Option 1, pre-production and validation, means the hospital has registered intent to submit data within 60 days of the start of the reporting period and is actively testing and validating electronic data submission. Hospitals must also respond to outreach from the public health agency. Failure to respond can result in failing the measure. And then option 2, validated data production, means testing is complete and the hospital is actively submitting production data to the public health agency. Beginning in 2024, CMS limited the use of option 1 to 1 reporting period per measure. For example, if a hospital reported option 1 for immunization registry reporting in 2024, it was expected to move to option 2 in 2025 for that same measure. Otherwise, the public health objective would not be met. CMS's goal is to move hospitals nationwide into sustained production data exchange, so public health agencies can reliably monitor population health and respond during public health emergencies. CMS has been clear that organizations can no longer remain indefinitely in registration or testing phases. So if you are not completely certain where your hospital stands on any public health measure, now is the time to verify engagement status. And please feel free to reach out if you'd like assistance reviewing this or if you need help getting in touch with KHI. Okay, moving on to scoring now. The Promoting Interoperability program uses a performance-based scoring methodology calculated at the individual measure level. Each measure earns points. Those points are added together to determine the hospital's total PI score, up to 105 possible points. That structure has not changed. What has changed is the total score required to successfully participate. For program year 2026, hospitals must earn at least 80 points to meet the PI requirements. And while a 10-point increase may sound small, I feel like operationally it is significant. CMS has effectively reduced the margin for error. Hospitals that previously passed comfortably may now be at risk if performance declines on even just one objective. Hospitals scoring below 80 points will not be considered meaningful EHR users and will be subject to a Medicare payment adjustment. It's also important to remember that hospitals must report all required measures to receive any score at all. So submitting a 0 numerator or denominator or answering no to a required yes or no measure without a valid exclusion results in a total program score of 0 and a payment penalty. And because of this, promoting interoperability performance must be managed as an ongoing operational metric throughout the year, not something addressed just prior to attestation. Our goal should be to proactively identify historically low performing measures and monitor performance regularly so there are no surprises at the end of the year. Now let's talk about electronic clinical quality measures. These measures use data captured directly from the EHR to help evaluate the quality of care provided in hospitals. For 2026, hospitals must report a total of 8 ECQMs, 5 required CMS selected measures, and 3 additional measures self-selected from the CMS approved list. There are a few important reporting rules to keep in mind. The reporting period is the entire calendar year, meaning all 4 quarters of 2026 must be submitted. Hospitals must also report the same set of EQMs across all 4 quarters. Measures cannot be changed mid-year. Unlike other PI measures, ECQMs do not have performance thresholds, so hospitals are not graded on outcomes. Instead, CMS evaluates whether data is accurately reported. The data must be submitted exactly as generated by your CERT through the hospital quality reporting system using any combination of Category 1 QRDA Category 1 files, zero denominator declarations, or case threshold exemptions. The table on this slide lists all available 2026 ECQM options with those 5 required measures highlighted in bold. And I know you've heard me say this before, but I've always found it interesting how CMS uses the word eligible when describing participation in these programs. Eligible hospital, eligible participant. And I suppose that's just CMS's polite way of saying mandatory, because in reality, hospitals don't truly have a choice. The payment adjustments established under the HITECH Act remain fully in effect today. That's why success in the Medicare Promoting Interoperability program matters so much, not just from a quality perspective, but for your hospital's financial stability as well. Hospitals must successfully attest each year to avoid a Medicare payment adjustment. For eligible hospitals under the inpatient prospective payment system, the adjustment is applied as a reduction to the hospital's inpatient payment update. Specifically, CMS reduces the update to the IPPS standardized amount by 75% for that fiscal year. For critical access hospitals, the impact is slightly different, but still significant. Medicare reimbursement drops from 101% of reasonable cost to 100% for that cost reporting year. So again, eligibility might sound optional, but participation is essential if you want to protect your hospital's Medicare revenue. All right, now let's take a quick look ahead. The fiscal year 2027 IPPS proposed rule was released by CMS on April 11th. This annual rule outlines proposed Medicare payment policies and hospital program requirements, including potential updates to the Promoting Interoperability program. So I want to spend a few minutes highlighting some of those key proposals just to give you an early preview of what may be coming and what hospitals should begin paying attention to now. These policies are proposals only, but they provide insight into where CMS appears to be heading with future promoting interoperability expectations. First, CMS proposed updating the definition of CERT for future program years to better align with evolving ONC certification requirements. CMS also proposed removing the ONC direct review and ONC ACB surveillance attestations from PI submission, which would reduce administrative burden during attestation. The next proposal is a significant one. CMS is proposing to remove the current health information exchange measures that require hospitals to electronically send summaries of care and receive and reconcile outside health information. CMS explains that these measures successfully drove adoption of electronic exchange capabilities, but today they often demonstrate that exchange can occur rather than showing that information exchange is meaningfully integrated into clinical workflows. So instead of counting individual referral loop transactions, CMS is signaling a shift toward evaluating how exchanged information supports ongoing care coordination and clinical decision-making. Importantly, interoperability expectations are not being reduced. If anything, CMS is raising the bar by moving toward measures that reflect continuous access to and active use of external patient information. In my opinion, these proposals appear targeted at situations where hospitals meet requirements using very small numerator and denominator values, such as reporting 1 out of 1 transitions for receiving and reconciling information, which CMS does not believe demonstrates true interoperability performance. For many of our hospitals, this is especially relevant because the sending and receiving measures are very commonly used. If finalized, organizations should be prepared for a significant shift toward one of the other HIE reporting options and may need to reassess workflows, exchange partnerships, and reporting strategies. So we will definitely be watching this proposal closely. Next, CMS proposed advancing interoperability between hospitals and payers by furthering automating electronic prior authorization processes. CMS also proposed adding a new measure requiring hospitals to electronically capture and exchange unique device identifiers, or UDIs, for implantable medical devices. And then finally, CMS proposed updates to the ECQM measure set, removing measures considered topped out or no longer meaningful, and then adding or refining measures aligned with current clinical priorities and digital reporting capabilities. So overall, these proposals continue CMS's broader movement toward fully electronic quality measurement, increased automation, and stronger alignment between interoperability and quality reporting. As a reminder, these policies, again, are currently proposals, so the final requirements may change significantly once CMS releases the final rule. We will continue monitoring developments closely ahead of the final rule, which is expected in August. And then, as always, we'll keep you informed of any updates affecting the Medicare PI program. Hospitals also have an opportunity to provide feedback through the public comment process. So we encourage you to focus comments on proposals that could meaningfully impact hospital operations, workflows, staffing, or your EHR functionality. CMS reviews all submitted comments, making this an important opportunity for hospitals to help shape final policy decisions. CMS said they specifically value operational feedback since real-world implementation challenges and provider experiences often influence how policies are finalized. To ensure consideration, comments must be submitted by June 9th, and you can use the link provided on this slide. Even brief practical feedback from hospitals can make a difference in how these requirements are ultimately implemented. So just keep that in mind. All right, to close out today's session, let's review a few key action items and reminders for hospitals as you prepare for the 2026 program year. This slide provides a quick summary of the key timelines for the 2026 Medicare PI program. As you all know, the reporting period takes place during calendar year 26, and then attestation occurs in early 2027. So the reporting year runs from January 1st through December 31st. The CMS Hospital Quality Reporting Attestation Portal is expected to open January 1st, and then the submission deadline has already been set for March 1st. And I also want to briefly just mention those hardship exceptions, although I don't anticipate any of our client hospitals needing to pursue this option. But CMS recognizes that unforeseen circumstances can sometimes prevent hospitals from meeting program requirements. And in those situations, hospitals may apply for a hardship exception to avoid the payment adjustment. A few important reminders: simply not having CERT does not qualify as a hardship. Hospitals must submit a formal application for CMS review and approval. And if approved, the exception applies to only one program year. And CMS also limits hospitals to a maximum of 5 hardship approvals per CCN over the lifetime of the program. This participation checklist, I think, is a helpful resource, and it does a good job summarizing the key requirements we've discussed today. So just to reinforce the essentials, hospitals must report on all required objectives for a minimum continuous 180-day reporting period. Hospitals must use CERT that meets the current ONC certification criteria. Hospitals must report 5 mandatory and 3 self-selected ECQMs for the full calendar year. And finally, hospitals must conduct or review security risk analysis implement risk management activities, and complete the updated 2025 SAFER guides. And these last ones, I think, represent some of the most important updates to the 2026 PI program. The key message from CMS is that assessment alone is no longer enough. Organizations must demonstrate action. CMS noted that many organizations were completing risk analysis, but not consistently addressing identified vulnerabilities. The new requirement reinforces that identifying risk and managing risk are inseparable parts of protecting electronic health information. CMS is not expecting perfection here, but they do expect progress toward risk reduction. Things like applying security patches, strengthening access controls, updating incident response procedures, addressing system vulnerabilities, conducting workforce cybersecurity training, and managing vendor risk. So if you have any questions, please reach out. We have a dedicated security risk analysis team here at the Kentucky REC, and they can assist you. And the expectation now is this ongoing process of assessing, prioritizing, and managing risk throughout the year. So not an annual checkbox completed right before attestation. And truly the same concept applies with the updated 2025 SAFER guides. So while the 2016 version focused largely on EHR implementation and configuration, the 2025 guides place much stronger emphasis on cybersecurity, system resilience, and ongoing operational safety. CMS is reinforcing that safe use of health IT is not just about having an EHR system in place. It's, again, about continuously evaluating how technology supports patient safety and protects electronic health information. Completing the updated SAFER guides will require greater coordination across IT, clinical leadership, compliance, and patient safety teams, because they are now intended to support organizational governance rather than function as a simple checklist exercise. And although the guides have been consolidated into fewer categories, when you look at it, each section really goes deeper now. So hospitals should expect this first year of transition to require additional time and collaboration. So the biggest takeaway here is simple. Don't wait until December. And unfortunately, CMS has not released many supporting resources yet for the 2026 Promoting Interoperability program. And when I say not many, I really mean none so far. So, however, the updated 2026 SAFER guides are available at no cost through ONC's healthit.gov website. And I've included a QR code on this slide so you can access the official site directly. As CMS releases additional materials, such as the 2026 PI specification sheets or other guidance, we will absolutely share those resources with you as soon as they become available. All right, in addition to assisting with attestation submission, I just briefly want to remind you of how the Kentucky REC can support your hospital throughout the entire PI reporting year. So for those doing the calendar math, July 5th is the last possible day to begin a 180-day reporting period and still end by December 31st. And with May quickly approaching, that timeline is really a lot closer, I feel like, than it may seem. At this point in the year, hospitals should already be validating measure performance, confirming the status, at least, of the SRA, implementing risk management activities, working through the updated SAFER guides or beginning to work through the updated SAFER guides, and then verifying public health reporting engagement status. The reality is that you can't fix PI at the end of the year anymore. Performance must be supported by consistent workflows and monitored throughout the reporting year. So to stay on track for 2026 success, hospitals should be running regular PI performance reports to understand where they stand. As a Kentucky REC client hospital, you can send those reports to us for review as often as you'd like. We have some hospitals that share them weekly, others monthly, but at a minimum, we recommend quarterly reviews so there are no surprises when attestation time comes. So if you've not yet shared a 2026 report with us, please feel free to send it my way. We'll enter your data into our gap analysis tool, and that provides a visual snapshot of current performance and estimates your potential PI score and really helps track trends in the individual measure level data over time. We are also happy to schedule conference calls or virtual touch base meetings. These can be used for questions, program clarification, or performance review. Some hospitals meet with us as needed, while others prefer standing recurrent meetings. So completely your choice. Just let us know. And with that, I want to thank you all for your time and attention today. I know we covered a lot of information, but if there's one key takeaway, it's this. I think promoting interoperability is no longer just an EHR program. It's a cybersecurity, interoperability, and operational performance program directly tied to Medicare revenue. So our goal here at the Kentucky REC is to make PI participation more predictable, manageable, and successful for your hospital. So please don't hesitate to reach out if you have questions or if you would like to schedule a follow-up discussion. Let us know how we can support you. We are here to help. Thank you again, everyone.